Welcome to this episode of Season 4 of The Common Bridge, where policy and current events are discussed in a fiercely nonpartisan manner. The host, Richard Helppie, is a philanthropist, entrepreneur, and political analyst who has reached over 3.5 million listeners, viewers, and readers around the world. The Common Bridge is available on the Substack website and the Substack app. Just search for The Common Bridge. You can find the program on YouTube and wherever you get your podcasts. The Common Bridge draws guests and audiences from across the political spectrum, and we invite you to become a free or paid subscriber on your favorite medium.
Hello, welcome to The Common Bridge. I'm your host, Rich Helppie. We've got a very important topic today. Remember the HIV crisis and the AIDS epidemic that was washing through the country and the world. A lot's been done about that. And here today to talk about it is Dr. Deborah Birx. Dr. Birx, welcome to The Common Bridge.
Thank you. So glad to be with you.
Dr. Birx is both a physician and a diplomat. She served in the White House as the coronavirus response coordinator under President Donald Trump. She specializes in HIV immunology, vaccine research, and global health. She oversaw the implementation of a program we're going to talk about today called PEPFAR, which stands for the President's Emergency Plan for AIDS Relief. And from 2014 to 2020, Dr. Birx was the United States Global AIDS Coordinator for President Barack Obama and Donald Trump, and served as United States Special Representative for Global Health Diplomacy between 2015 and 2021. Dr. Birx, you've been obviously busy during your career. What other parts of your biography would you like to share with the listeners, readers, and viewers of The Common Bridge?
Well, I was very fortunate to have a husband that my first husband took the Army scholarship, and that made it so that I had to join the Army to be with him. So I actually did my residency, internship, and then 29 years on active duty in the U.S. Army in the Medical Corps. During a time just post-Vietnam War, it was a very difficult time, transition to voluntary service, elimination of the draft, got to see the military go through all of those changes. And I have to really thank the military. They forced us on management, leadership, budget, acquisition, training. And at the time, as a physician, I was like, why do I need to know all of this stuff? But the leadership and management skills that the military spends real time on throughout your career, and frankly, you can't get promoted from major to lieutenant colonel or lieutenant colonel to colonel without doing advanced courses and command and general staff school. And it was a real privilege to have that training because it served me well once I got into the civil service, really, and supporting PEPFAR for 19 out of its last 20 years.
That training that you get in the United States Army is really unequaled any place in the world. Great discipline because there's very little room for error in the military. Dr. Birx, I understand that the President's Emergency Plan for AIDS Relief, PEPFAR, is coming up for a renewal or an anniversary. Tell us a little bit about what exactly is PEPFAR. How does it work? What's been accomplished? What's this date of the 20 years or longer? What's this all about?
Richard, you're right. It's the 20-year anniversary of the start of the program. I think three things really set PEPFAR apart. Was in government for 40 years, so I really know how to make government work. But PEPFAR took a different approach to foreign assistance and was the largest U.S. investment in battling a pandemic, took a comprehensive approach. And what President Bush said was we could do things differently in a new way that would have a greater impact. Now, you have to break a lot of eggs to do things differently within the federal government. And so he really told the agencies to work together in a new way. And really, I would say at the beginning, forced USAID, CDC, Peace Corps, Department of Treasury, Department of Commerce to all work together, and Department of Defense in a new coordinated way where we weren't duplicating each other, but we were building off of each other's strengths. And that may sound like common sense, but in a highly structured and bureaucratic federal government, there's a lot of silos and a lot of this belongs to me, you can't have it.
Well, President George W. Bush was our first president with a business degree, and it's fairly routine that in business you focus all resources on the customer or the problem or the opportunity. And
well, you know how matrix management became a big deal in the 2000s? Well, this was the first matrix managed program. And I think brilliantly, they decided that the Department of State, which wasn't directly implementing themselves, would be the group that would oversee the other agencies and determine the budget that goes to each agency, which allowed the State Department to really just follow the data and use data in a transparent way to hold the program accountable, and frankly, to hold the agencies accountable, holding the partners accountable, holding the communities accountable, and critically holding the host governments accountable.
So what type of data was tracked and what actions were taken based on that data?
So at the very beginning, at the start of PEPFAR in 2003, the UN AIDS data on the depth and breadth of the pandemic in each of the countries was utilized to determine the initial investment.
Was this all sub-Saharan Africa at this time?
No, it included Haiti and the Caribbean and Guyana and South America. And then 13 and Vietnam was added as the 15th country. So sub-Saharan Africa, the Caribbean, South America, and Asia. And that was really important because you can only be successful if you understand the cultures and the partners and the local community on the ground. So the program had to be tailored to each of the individual countries. And that is the second big deal about PEPFAR. PEPFAR was never attempted to be run from the US. It was run internal to the countries, where actually the US ambassador in that country was responsible both for execution of the program and oversight of the program, and worked with the central group, the SCAC, where I was in charge for 7 years, to really define funding and oversight. And so the data was originally based on disease burden. Then it became very much focused on understanding precisely where the people were that we needed to reach by age, by geography, by race, by ethnicity, and by tribe, so that we could ensure and hold ourselves accountable to reach both the groups that were marginalized by the host government, the LGBT community, or young women who were marginalized. We were able to use data to see precisely who we were missing. Now, doesn't this sound like something the U.S. should do?
Well, the interesting thing about this is that for my audience, I know there are many medical professionals there and public health people. But for your average person not involved in this, if I understand what you're saying about the host governments and about our ambassadors being responsible, but a person suffering from AIDS or at risk of, suffering from an HIV infection or perhaps at risk, how did they get located? And then what services were they offered to remedy that? And then what was the data checkpoint to see how effective it was?
So really great series of questions. So it was grounded in originally reaching everyone who needed our support, both with prevention services and treatment services. Obviously, at the very beginning of PEPFAR, it was very much focused on reaching those who were dying. And so really put a lot of effort early on in the program in reaching those people who had symptoms and were sick from HIV/AIDS, and ensuring that they were on lifelong effective treatment that allowed Americans that had been on that type of treatment for almost a decade, allowed people around the world to thrive now, for moms and dads to be able to raise their family, and for moms to be able to have children without HIV. So that was the original focus. As we became more capable and working within countries to find out where everyone was, as you just described, we started doing outreach further and further into the more and more remote areas. And then we added in 2014, because you're getting to a very important concept. When you're delivering services, you can only see the people who come for services, whether it's services to prevent HIV or services to treat those who are impacted by and had acquired HIV. So you only see what you see. And that's always a problem if you don't have another system. And what we put in is community level surveys, household surveys, just door-to-door surveys, so that we could see both who we were reaching and who we weren't reaching, and then tailor the program to understand what we needed to do and what the barriers were from keeping those individuals from accessing services.
All right, so imagine I'm in a remote village in sub-Saharan Africa, and I live there, and a medical professional arrives at my home. And what do they tell me? What do they ask me? And what do they do for me?
So very important. That doesn't happen without all the pre-work. So to go into a local village, we would meet with the village chief and the village elders and the leaders, and talk about what we wanted to do and listen to what they wanted us to do, and really come to a consensus of what we needed to do, whether it was service delivery or whether it was this survey. And then we would come in with education at the community level before, and that could be at churches, that could be at get-togethers where we serve food, where you would really have the community engage and do an overall education. And then we would go door to door, or then we would open the clinic in that community, so that trust had been established, relationships had been established, and we were able to really educate and inform and get feedback and listen. And I think the biggest thing that we did is we listened to communities about what their needs were, and met communities where their needs were, and then layered on the HIV prevention and treatment services.
All right. So, okay. And so I understand this. It's a socialization, not coming in cold, coming through the government structures and tribal governance structures, if you will, depending on what was there. And now, what are the services? Are they testing? Are they treatment? And what did you find, and what did you do?
So at the beginning of PEPFAR, on all of sub-Saharan Africa, with millions of people who were infected, there were only 50,000 people on treatment. And those who were on treatment were having to pay for treatment. So they would go on and off treatment. And so it was I worked in Africa before PEPFAR and before the Global Fund. And I'm one of the few who was there before and understands the level of devastation. In some countries, 40 to 50% of every adult was already HIV positive.
How many?
40 to 50% of every adult.
Every adult was already HIV positive. Okay.
And in much of East Africa, where I had most of my experience in the late 90s, it was about 10 to 15% of every adult was HIV positive. Mm-hmm. Every weekend was filled with funerals. Whole villages were losing their teachers, their police, their politicians, their moms, their dads, their grandparents. ripping apart the social fabric of sub-Saharan Africa. And I think what President Bush said is we're going to respond to that in a comprehensive way. So you are right. There was a whole, just like there were all agencies were involved, there was a whole suite of critical services involved. What did that look like? There was an orphans and vulnerable children's program to really provide support, whether it was food and nutrition, whether it was HIV testing, whether it was HIV prevention for young children who had lost either both parents or a parent. There was comprehensive programming for those who were dying. And comprehensive palliative care so they could die with dignity if we couldn't turn their cases around, which in most cases we could, but we had to attend to the people who were suffering. And so there was that whole palliative care piece. And then, of course, there was testing so that people would know if they were HIV infected. And then there was the medication that prevents the progression of the disease. And what we've learned is it not only prevents the progression of the disease, but it prevents transmission to others. So now you can start to see not only are we saving people's lives, but we have the potential to change the very course of the pandemic. Early on, we had.
So those are, I think, in colloquial terms, those are known as a medication cocktail or a pharmaceutical cocktail, but there's a more technical term for that.
Well, they were called our antiviral drugs, and they're as you described. It was a combination drug or an ARV cocktail of drugs, three drugs at that time that in the U.S. cost about $25,000. But because of, again, the whole of government approach, the FDA worked with branded companies to transfer their technology, and we were able to use generic drugs. At that time, cost about $1,200 a year. By the time I left the program in 2021, it was down to about $75 a year. So you can imagine cost then of the drugs then becomes a relatively easy piece of the cost structure. Reaching people, as you describe, becomes the critical element, because you have to reach people who don't normally interact with the healthcare delivery system. And we have that in the U.S. too. You know, both young men and young women don't normally interact with the healthcare delivery system. Young women don't unless they happen to be pregnant. Young men, and actually, frankly, middle-aged men and older men don't want to interact with the healthcare delivery system. So we had to really work with the private sector, and that was the third point of PEPFAR. Yes, we used data, we saw our gaps, but we also realized that sometimes we needed private sector to come in and help us address those gaps. And they were critical in both testing, but also reaching young women through what we called our Dreams program that was focused on young women, and MenStar, which was focused on men, to really get men into treatment. But
I know one of the terms that you publish is something called key populations as being most prevalent for HIV. What is a key population, and how much of the disease is concentrated there?
So the key population component evolves. So early on, what I was describing, whole communities were infected. And so when you treat people in global health often call it the low-hanging fruit. Once you get to the people who are available and motivated and already sick and seeking treatment, that's very different than reaching the well. And reaching the well with prevention. And so the people at risk for HIV infection continued to evolve over the course of the program, because as we began treating people that were symptomatic, we could get to the next group and the next group, to the point where we were to what we call key populations. And those were really very evident populations throughout the pandemic, but became the group that was the largest gap. And who were those individuals? Particularly young women between the ages of 15 and 25, where the rate of new infection was very high. men who have sex with men, people who inject drugs, people who are imprisoned, sex workers. Those became populations that we had to focus on. And we had to work with governments to create an environment where individuals that were stigmatized and marginalized within communities. And believe it or not, young women are stigmatized and marginalized within communities often, as well as the key populations of our LGBT community, men who have sex with men, people who inject drugs, prisoners, and sex workers on the margins of often communities. And we had to develop programs that ensured those individuals could have access to programs that were non-stigmatizing and non-demeaning and listen to their needs and ensure that we were addressing their unique set of needs.
I want to understand how the young women fit into this, in that NBC News did a study, and I think it was used in the President's State of the Union address just this past February 7th of 2023, that says half of the new cases, now again, not going back all the way to the beginning of this, but half of the new cases in the region are coming from key populations and their sex partners. And they said this is only 5% of the population, but responsible for over half of the infection. It includes men who have sex with men, transgender people, sex workers, and people who inject drugs. That seems like a great target of opportunity with a small population to take out perhaps more than half the cases. How does PEPFAR deal with that?
So I'm going to rewind us for just a second, because we've decreased the rate of new infections by more than 50%, and in some countries by more than 75%, and in some countries
how is that decrease? How's that decrease measured? And I ask because I've got a background in health data, and I understand as you're going in and doing these first surveys, there's no baseline. You perhaps didn't know exactly what you were going to find. It would have been impossible to know. How did you go about measuring that rate of decline?
So really critically important. From the very beginning, the advantage that we had in the HIV world is there was a program called UNAIDS, who was very data-driven also. So they had began collecting data since the 1990s and had developed what we called the spectrum model, but it had never been validated, which is a great point that you are making. And so those early surveys at the community level that we did in 2014, and that some governments did before that, that includes Swaziland, we funded one earlier than that, Kenya and Botswana and South Africa, who are regularly doing surveys. These surveys were being done on a regular basis. You're absolutely right. We use those community level surveys to both validate the UNAIDS spectrum model, as well as create that baseline. And now in most countries, they've not only had one survey, they've now had two surveys. So we can see precisely the improvement in the program. We can see precisely the gaps that persist. And we can ensure that our programs are aligned to reach the individuals who are missing. Because it's easy to keep reaching the ones that you've already reached. It's very difficult to reach a population that 20 years in, you're still missing.
How is it that they're still outside the survey boundaries?
So they're in the survey, so that we picked them up in the household survey. So they came in as HIV positive, what we call not virally suppressed, not on treatment. So they hadn't been diagnosed, they weren't on treatment, and they weren't virally suppressed. But again, reminding you that we have already reached, as you described, the majority of the population and dramatically decrease the rates of new infections.
Well, that was the original question, was how do you know
right.
that?
So we look at those incident rates.
Was the test mandatory by the local governance that if, look, we're going to do this survey and everybody in the household is going to give a blood sample?
So you made a really critical point. All of the participation in the surveys are voluntary, and that's why the education is so important, as well as knowing who's refusing. And so we have very few refusing, and all these surveys are, majority of them are on the website of ICAP, which was a critical partner. So if you go to AIDS indicator surveys, they're called FIAs. You'll find all of them online, and the repeat surveys online. So we have very good participation rates across age groups. And that allowed us to look at over time. What you're getting at is, what is the actual incidence of new disease versus what is the incidence of people who are already infected and on treatment?
Yeah, and because you did mention a key population, young women, yet as recently as February, that young women aren't even in the key populations. So I'm just wondering if there's data that says, okay, it's been eradicated. And I guess as a technical point, as I'm not a scientist, why is it that the key population, the at-risk populations, men that have sex with other men, transgenders, sex workers, people that inject drugs, why is it that they continue to be such a source of that, and what can be done about it?
So, a series of questions there. So, there was a program that we developed called Dreams Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe. Young women started in 2014. Across the board, we've seen a 50% decline in the rate of new infections in young women, but it's still a persistent group. So you have to constantly ask yourself, what do I need to do more? What do I need to change in order to reach that young women's group that has not been reached in the last 9 years? The same way with key populations. Although in some countries, key populations have been reached, in many countries, because of criminalization of LGBT behavior, it becomes very difficult. And that's why the three core ways to battle a pandemic is you have to have political will, because the political will allows presidents of countries and their ministers of health to see the pandemic that they have based on the data, not the pandemic they want to have. And that is a very important distinction, because you have to use data constantly to tell them this is the pandemic they have today, and this is how we have to change policies to make an environment where people who are being criminalized can access services. And I think that is the gap that still exists in many of the key population programs. On the converse of that was a highly successful key population program out of the Ukraine that we had been funding for several decades, where the local governments realized that the federal and the national government could not do everything, that key populations in general were not going to always come to public sector clinics. And so they funded, and we funded in PEPFAR, peer outreach and peer-led clinics or services, where people who were injecting drugs could go to a clinic where there were peers there that were no longer injectors, that really worked with them through all of the behavioral issues, as well as diagnosis for their HIV and treatment. And so that kind of model of community-led peer outreach has been highly successful with key populations. We have a lot of countries where it's been successful. But in sub-Saharan Africa, in many of the countries where MSM behavior is criminalized, it becomes very difficult to reach those populations. We were able to reach them because we were able to work with governments to allow us to have outreach workers. Now, with the new legislation that's coming out of Uganda, it's very concerning, because if Uganda passes that legislature, it's very common that Kenya and Tanzania and Malawi will follow suit.
What is Uganda considering?
Uganda just passed a bill through their legislation that increase the criminalization of MSM behavior, and further increase the penalties around any behaviors known to be that, and encourage people to turn others in. And so now you're starting to pit communities against each other. And if you want a pandemic to expand, that's the way you do it, where you create a environment of discrimination, increased vulnerability, and lack of fracturing trust all along the cascade.
Yeah, sure. I mean, nobody's going to be candid if the result of the test might mean they're going to be incarcerated in a horrible place for the next 20 years versus get treatment. I can see where that would just exacerbate the problem inside those key populations. So the program is coming up for a review or a renewal. What's that about?
So remember that President Bush worked with Congress, and there's another key point about PEPFAR. It's bipartisan. Was bipartisan in 2003, and is bipartisan.
Bipartisan. What's that?
I know.
Well, wait a minute. I think Lake Superior State University said that was one of the words that they're taking out of the dictionary now. I'm just kidding. I just
no, it's so
I discussed with the political the two major parties. It leaped to the fore, but the 20-year. This is a 20-year anniversary.
So every 5 years, it has to be what we call reauthorized, because it is a different structure. It doesn't belong to one agency. We often will fund through a specific agency. This belongs to the entire federal government, funding executed through State Department. And so that structure is different than a lot of the other foreign assistance. And so every 5 years, it has to be reauthorized. It was reauthorized in 2008, 2013, 2018. I got to oversee the end of the 2013 and the 2018 reauthorization, and now we're into the 2023 reauthorization. It is a very important time, because I found when I was in the program that congressional members and their staff were really helpful in constantly looking at the program and making suggestions. And within this reauthorization, they can change what we call reporting language on what data is collected and what reports they want to see on what the program is doing to address. So it'd be very common for them to ask your questions. How are you doing with new incidents of disease? What are you doing to combat the group, even though you've decreased it by 60%? What are you doing for the last 40%? What are you doing to reach the 5 to 10% of those who haven't been reached that are already HIV positive? Those are the kinds of reports that Congress can ask for. They can ask for a report on how PEPFAR created the platform that actually made it possible for sub-Saharan Africa to respond to the COVID pandemic. So those are the kinds of reports that can be asked for within this reauthorizing language. And so this reauthorization is important. It's probably one of the last ones that PEPFAR needs to do, because the whole purpose of PEPFAR was be successful, stop the program. And the fact that we are this close to being successful, PEPFAR went from 50,000 on treatment to 20 million on treatment. So we know how to battle pandemics in a cost-effective way. And that was with a flat budget. So I'm going to remind the American people, all of this program improvement was driven by data in a flat budget. And that's why the data also is critically important, because if you have a flat budget and you have to expand something, you have to contract something else. And you can't make excuses, because people's lives are on the line. So you can't be coming back to whether it's President Bush or President Obama or President Trump or now President Biden and saying, I can't do this because I don't have the money. No, you come and say, I can do this. This is what we're going to do. This is what the needs are now. We're going to stop this parts of the program. We're going to expand these parts of the program. When was the last time you heard that in the United States? that, we are looking at the data, we're going to expand this part of the program, and we're going to contract this part of the program. That's the value of PEPFAR.
And I know your question was a bit rhetorical, but I think this is one of the issues that we have. And you mentioned the coronavirus and the pandemic there. And look, there's no mincing words here that the scientific community took a hit. The CDC took a hit. Things that are coming to the fore now that the 6 foot rule was frankly just made up. That the lockdown policies were really ill-advised, the closing of schools ill-advised. We couldn't be candid about the effectiveness of the vaccine, and things like natural immunities and other treatments being swept under the rug. And then more so, when people see that the people imposing the policies, Governors Whitmer and Gavin Newsom from California, the mayor of Denver, among others, people are going to look at this with a jaundiced eye. And I just have to think that some of your pursuits of getting this renewal is going to run into a heavy wave of skepticism because of COVID. And that's speculation on my part, but I'm trying to put myself in a position of a rep. I'm going to be asking a lot of data questions, and I'm going to be saying, show me your work, given what we've seen happen over the last several years.
Thanks for joining us on The Common Bridge. Subscribe to The Common Bridge on Substack.com or use their Substack app, where you can find more interviews, columns, videos, and nonpartisan discussions of the day. Just search for The Common Bridge. You can also find The Common Bridge on Mission Control Radio on your Radio Garden app.